Thank you for joining us for our first center webinar to talk about issues with knee pain. And I'm going to try and keep this pretty interactive and stop briefly through the talk to answer questions, especially if they're pertinent to what we're talking about at the time. But without further ado, I'll let you know what we're going to go over this evening. So I do want to focus this talk on knee replacement surgery and how it relates to knee arthritis, as this is one of the most common causes of knee pain throughout the country. And especially with a population that is getting a little bit older, it is very, very relevant for today. So I want to go over the main causes of knee pain, and we see many, many different types for an active community like the people of Central Oregon. And it can be everything from overuse injuries like bursitis and tendinitis to long-term overuse and even age-related or genetic-related arthritis. So I'll touch on that as well. But it is very important that we at least go through some basic anatomy so that we're all on the same page for this talk. So first I start with going through the bones of the knee, and there's 4 major bones. I'm going to use my pointer here and try and circle here. Good. And so we have the femur, which is the thigh bone. We have the tibia, which is the shin bone here. And then we have the kneecap patella. And then what acts as a strut and a muscle attachment point, along with a ligament attachment point, is the fibula. But the main weight-bearing bone of the knee is the tibia and the femur, and those carry most of the weight. The kneecap is very important as it acts as a fulcrum and a way for us to use our knee as a lever, especially when going up and down hills, and that's when people can have a lot of kneecap issues, is when they are going up and down hills regularly. And that is one of the most common complaints that I hear about knee pain, is that it's usually when people have been very active, either carrying weights up and down hills. And you can't talk about knee pain and the function of the knee without talking about cartilage. Cartilage is extremely important for the function of the knee. Cartilage is the lubricated surface on the ends of the bones that allow the knee to move and allow the femur to move past the tibia, and the kneecap, the patella, to glide over the femur. And it is made out of hyaline cartilage, so it's a connective tissue that doesn't have any blood flow to it. It gets all of its nutrition from the knee fluid in the joint, which we all have normally in our knees. And the cartilage itself is about 80% water. So it is a very durable substance, and it has very, very little friction, 5 times less friction than ice sliding on ice. So this is what allows us to walk using our knees every day for many, many years. And related to the cartilage is the meniscus pads. So these are 2 firm cartilage pads, and I'll point these out here, 1 and 2, each knee. Sorry about my drawing with the mouse, but each meniscus pad is made out of firm cartilage, and it helps stabilize the knee, and it helps act as a shock absorber. So many folks have issues with tears of their meniscus. Can happen as a knee injury, or it can even happen just with wear and tear over time. But they also have very little blood flow, only coming from the edge of the meniscus. And so they don't heal very well. This is why folks can have problems with their meniscus. And they're on the perimeter, on the outside of each part of the joint. And moving to the next slide. Ligaments are critical for the stability of the knee, and we have 4 major ligaments, 2 on the outside, the inside medial collateral ligament, and then the outside lateral collateral ligament. And then in the center of the knee, in the picture down below, you have the ACL And that acts as a front to back stabilizer, and then the PCL, which is also a front to back stabilizer, and it attaches right there. And people can tear these, especially with significant injuries or in sports especially, but they are also important to talk about. And then tendons are also critical, and a lot of folks can have issues with tendons of the knee. One of the major causes of pain I see in runners is IT band tendinitis, which is on the outside of the knee, and it can be just a tendon that runs over the side of the bone and can cause a lot of irritation with overuse. People can also get a lot of front of the knee pain, which is patellar tendinitis or jumper's knee, also very common. But the patellar tendon and the quadriceps tendon attached to the kneecap here, and those are what allow us to extend our knee. So very important structures. And then, so I want to get into some of the main causes of knee pain, a few that we've already touched on. We talked on a little bit of patellofemoral pain, which is that kneecap, front of the knee pain with going up and down hills. And then we talked about the IT band tendinitis. But you have to talk about bursitis, which is very common. And bursa is a loose connective tissue that resides under tendons, and it allows tendons to slide over a moving joint. Because as we bend our knee and extend it, there are tendons that have to move around, and not everything can be connected to each other. They have to glide freely. So these bursa areas can get really inflamed and sore and swollen. And as you can see in this picture with the green dot, that's a patient with front of the knee bursitis. And it can get very swollen, but it's not particularly dangerous or anything. So we talked a little bit about those meniscus pads, and they can have many different types of tears. In the picture in the front of the screen, you'll see this is a meniscus that has a very chronic tearing. So folks can say, oh, when they come into clinic, I have a meniscus tear. And it can oftentimes be something that just progressed over time, that they just noticed it without a particular injury. It could be, on a long hike, and after getting back, they notice some clicking or catching of the knee. And that's because this meniscal tissue that you see really frayed here in the picture is getting caught in between the two bones. And it can be quite painful. Most folks feel it right around the side of the knee, either outside or inside, more commonly on the inside. And there's really two ways to treat it, which I'll address later in the talk. Ligament injuries are critical. I'm not going to get too far into these, but one of the most common ligament injuries we treat is the ACL tear. It happens in a lot of athletes, especially here in Central Oregon, many skiers, soccer players, even mountain bikers, dirt bikers, and it's a rotational injury of the knee. So that's a common cause. And when that happens, there's usually a significant injury and a lot of swelling. So very common injury, but it's very noticeable when it happens. So the talk will be more focused on long-term and short-term cartilage injury. And what you see here in the lower left picture is a cartilage injury on the knee looking through camera when we do a knee arthroscopy and we're looking through cameras to address the issues of the knee. You can see here that this nice smooth white is normal cartilage. That's what it looks like, and that is very smooth and allows free motion of the joint. But below it, you can see the kind of more in this picture, a little bit yellower, and that is bone underneath. There's bone directly underneath that cartilage, and that is quite rough. And when you get issues with bone interacting with other cartilage in the knee, pushing on and gliding past other cartilage or other bone, it causes quite a bit of pain. There's more friction and more inflammation that comes along with that. And so this is a good picture that I always like to show that is what arthritis looks like. It's more or less the main culprit. And this picture, you can see the little metal probe in kind of the bottom right. Above it, you see that pink and kind of ratty looking tissue, and that's the end of the femur bone. So that kind of oval structure is the femur bone on the inside of the knee. And you see a lot of damaged cartilage here, and the pink portion is bone. And so that's pretty much what arthritis looks like when we have it. And it causes a lot of inflammation. It causes swelling in the bone, which is quite painful. It causes inflammation of the capsule of the knee, which is that surrounding tissue that goes around the knee and around the structures and holds the joint fluid and helps protect and nourish the knee. Well, that capsule can get quite inflamed, and it is quite painful. So when I see people that come into clinic that have a problem with arthritis on one part of the knee, a lot of times they feel it all around the knee just because the whole knee can be inflamed. And there can be many different causes. The most common cause of arthritis that we know most commonly is osteoarthritis, which is general age-related wear and tear arthritis. And that's the inflammation from the loss of cartilage. But there are other types of arthritis, including inflammatory arthritis, like rheumatoid arthritis, which is our immune system attacking joints. And also gout can be another type of arthritis, which is when crystals get deposited in the joint and create a lot of inflammation. So many different types of arthritis. And let me see here. We have, so I have a couple questions here. And let's see here. Talking about cortisone shots and treatments for Baker's cysts. So I am going to address that in just one of these slides very shortly. So we'll get right there. So common symptoms, a lot of grinding, walking, catching, pain with either prolonged sitting or standing or prolonged walking. A lot of folks can say, I can only walk 2 miles before it starts hurting and I have to sit down, or etc. We do see bone spurs. Folks say they have bone spurs in their knee joints, and that is actually a reaction of bone. It notices increased friction and inflammation, and our body tries to heal it with the best method it knows. It doesn't know how to make more cartilage. It can only make more bone. And so those bone spurs are our body's reaction to the arthritis. So that can be more of a symbol, not an actual cause of the pain. Another cause addressing the question is that we can get increased fluid in the joint, and that can go out the back of the joint. There's a little bit of weakness in the back of the knee, kind of in the crease, the fold of the knee, and it can create a Baker's cyst. And that fluid can collect in the back of the knee. It's not an actual growth or anything. It's just joint fluid that gets caught in the back of the knee. So we can treat those, and those can be either drained. I don't usually recommend that. That's where the blood vessel and nerve run right in the back of the knee. So there is some risk there. But usually cortisone injections do actually help decrease the fluid production in the knee, decrease the inflammation, and actually help the cysts go away with time. They can recur, of course, but usually it's very helpful for many months, on the order to 3, 4, 5, even 6 months. Let's see here. And so this is another good picture of that inflammation. I'll kind of mark it out so you guys can see. And this is basically the lining of the knee. And when it gets really inflamed, there's more blood flow to that tissue, causing pain molecules to circulate around the knee. And it looks just like this if we looked right at it. So very, very sensitive, very painful. And of course, we always have to be careful making sure we don't miss a fracture. Even in the setting of arthritis, some bone can get a little bit weaker and can cause a small fracture, especially with overuse. So we always like to get x-rays. It's very important. I'm going to be talking a little bit about prevention of broken bones. One slide I always like to include in my talk is this, because it was actually a study done by one of my mentors down in San Francisco. And he was actually a gentleman who had a friend of his, another orthopedic surgeon, do a knee arthroscopy of his knee without anesthesia. He just had a little bit of local anesthetic for the skin. And then he was fully awake to see what hurt and what didn't. And you can see this was back in 1998, and all of the black areas in the symbol of the knee are the areas that were very, very sensitive. And that's the capsule, the lining of the knee. And also right under the kneecap, there's a fat pad, a collection of fat that is also very tender. You can see around the capsule, it's a little bit grayer. It's sensitive, but not quite as much. But the ends of the bone is actually not quite as sensitive. The kneecap had very limited pain fibers, pain reaction, and same with the cartilage on the bone. So is a lot of what we feel is the sensation of the lining of the joint and a little bit around those meniscus pads. So a very brave soul for doing that, but good information for us. So what can we do about it? I want to go through some of the basic conservative treatment measures, and then we'll get into talking about the surgical options. So I'm sure many folks have heard about RICE treatment. So rest, ice, compression, elevation, and non-steroidal anti-inflammatories, including ibuprofen or Aleve. We sometimes prescribe meloxicam, a longer-acting anti-inflammatory. All of these are very, very helpful and can give us quite a bit of relief. So a very good start. And a lot of my patients usually have already done this by the time they come to see one of us. Always have to mention, if this doesn't work, it's important to come and talk to your doctor. Make sure it's nothing more serious, especially in situations where you're having difficulty bearing weight. Redness, swelling is also very important, especially in the setting of any fevers. Have to go to the doctor. Loss of knee motion is a very common cause of, or very common symptom of significant problems in the knee, including increased swelling, painful or unstable clicking and popping. That's oftentimes related to broken cartilage or meniscus pads. And then being unable to perform the activities you enjoy. Also very important to know about and address with your doctor. Like I said, it's very important to get x-rays. It gives us kind of a general baseline understanding of each patient's knee. Braces sometimes help. I'm not the biggest fan of braces. I know everybody has a little bit of a different theory on them. Some of the most supportive braces limit motion a lot and are very cumbersome and difficult to wear on a regular basis. They can cause irritation of the skin. They can be expensive. So I really leave it up to the patient. If it helps, that's great, and it's worth a try, but I definitely don't say it's an absolute must. And the idea of a brace is it helps, especially in arthritis, if there's a part of the knee, usually the inside of the knee, that's having problems with wear and tear, you can help put a little pressure on the knee, correct the alignment, and help load the outside of the knee more than the inside of the knee. And that's the basic theory behind it. Other anti-inflammatories, we talked about the non-steroidals, NSAIDs, but cortisone is a long-acting anti-inflammatory, and this is a really beneficial treatment. There's been a lot of publicity and press about the fact that cortisone can be detrimental over time. The way I like to describe it is that cortisone used in small doses can be very helpful to get us back to the activities that we enjoy. It can decrease swelling, decrease pain, and allow us to get back to the hikes and traveling that we all want to partake in. A lot of times, what we're doing cortisone in joints. We're injecting cortisone in joints that are already not healthy. They already have damaged cartilage. It's already unhealthy cartilage. And so when you do cortisone shots over many, many years, it can break down cartilage more rapidly. But it is already a joint that has very little cartilage to begin with. So if it does help, I like to use it in situations where it helps patients get back to the activities they enjoy, being with their kids and grandkids, being able to go outdoors with their friends. And that can be a great way to put off surgery to a better time or later year when it is either better for schedule or to be able to put it off indefinitely in some cases. But we don't generally just inject cortisone in healthy knees, and because it can definitely break down cartilage. We do know cortisone can do that. Physical therapy can be helpful. There's also a lot of theories on this. You can do another 2-hour talk on physical therapy alone, so I try to keep it brief. But a lot of it's focused on range of motion, stretching, and strengthening, and improving overall muscle function to help balance the knee and help support different parts of the knee. And it does work quite well. I don't like to prescribe it in settings of significant arthritis. because that can actually overload the knee and cause more inflammation. So I use it in earlier stages, or some of the other more overuse syndromes, like the bursitis and the tendinitis that I talked about. The other type of injection that maybe some of you know about are these lubricating shots, hyaluronic acid, and they've been coming out for the last 15, 20 years so, and have had good literature during this time period showing that they really can help folks quite a bit and decrease a lot of inflammation for a long period of time. Say 4 out of 5 patients get significant relief for about 6 months. It's usually a series of 1 to 3 to even 5 injections, usually around 3 injections, sequentially over a 3-week period. But they can help quite a bit, and it's really good for patients with mild to moderate arthritis, so definitely not the bone-on-bone candidates. And then MRIs, I like to do a slide on MRIs just to touch on it, because MRIs are very important for showing us the soft tissue structures of the knee. You can see here, I'll point it out, it's what a knee MRI looks like. But this is actually the femur bone, this is the kneecap, this is the patellar tendon, and this is the tibia bone. And you can see this gray line along the bone is actually the cartilage. So you can assess the cartilage. These triangles are the meniscus pads. And you can actually see that there's a tear in this meniscus pad. It's the white line going through this triangle, if you can see that. So it gives us a lot of information about the soft tissue of the knee. It's important in patients with decreased degenerative problems of the knee. In the setting of arthritis, MRIs aren't very helpful, and a lot can be assessed just on X-ray alone. But if we're looking for an isolated meniscus tear or an isolated ligament tear, cartilage injury, MRIs are fantastic, and we use them all the time. All right, and then I did want to touch on fracture prevention. It's always very important, staying active, healthy, maintaining weight, and at an appropriate level, and also in folks that are over the age of 50, women over the age of 50, and certainly men over the age of 70, it's recommended to be taking 1,200 milligrams of calcium a day and daily vitamin D, 600 international units. And that's very helpful in fracture prevention. So before we jump on to surgical treatments, let's see what other questions we have here. So John here asked about healing a stress fracture with exercise and nutrition. So that's a good question. There's many different types of stress fractures. They can occur all throughout the body. It's definitely an overuse injury. It can happen in even very healthy long distance runners. It can happen in all of us. But usually the treatment is staying away from the exercise that's causing it and decreasing the load on the actual bone. And then nutrition is very important to maintain a healthy diet, and even making sure that our calcium and vitamin D is adequate. So also very beneficial to do for healing stress fractures. So let's talk about surgical treatments. So one of the main surgical treatments that I perform every week and multiple times a week is knee arthroscopy. It's a minimally invasive surgery, usually 2, 3, 4 portals, pretty small, less than half an inch in size, and it allows us to look all around the knee joint and address many of the problems of the knee. It's usually an outpatient surgery. Many patients can be walking on their knee right afterwards, and the downtime is minimal. The problem is that its application has been limited somewhat. It was widely used for arthritis, but it's been shown that it's not very helpful for cleaning out arthritis. I use the term clean out. Really, it's a shaving of the damaged cartilage. I think some folks think that it's going to be cleaning out the plaque, cleaning out the debris that's accumulated with arthritis, and that's not the case. It's when there's wear and tear going in there and moving it around and shaving it a little bit doesn't really help for a long time. Sometimes it can help clear out the inflammation temporarily, but it hasn't been shown to be much better than a lot of the conservative measures that I just talked about. Now, that being said, when you do have meniscus tears, cleaning out the torn part of meniscus can be very helpful, and I'll try and point it out down here. When there is a tear of the meniscus, you can basically just remove the damaged part of the meniscus and leave the healthy tissue remaining, and that does solve the problem many, many times. And in other circumstances, you can perform a repair of the tear with a suture, with a stitch, and that can help hold the meniscus together and help it heal. But this is only in scenarios where the damage is acute. It's happened all at one point in time, and there's not a lot of wear and tear, and it's in an area of the meniscus, like the outside of the meniscus, which they're showing here, where there's good blood flow, which will allow it to heal. And then surgery for arthritis. I'm going to talk about the knee replacements. So a knee replacement, what is it? It is basically, at this day and age, we've have very good implants that have been perfected over many, many years. And what we have mostly gotten down to is basically a metal cap that covers the femur that we place with either cement or directly on the femur bone, and I'll point that out, and also show there's some animations coming up that I'll show you. And then a metal cap that gets cemented or pressed into the tibia bone, and then a polymer spacer that goes in between the two. And this is where joint fluid gets in between the metal and the polymer and allows near frictionless gliding, so the bones can move past each other. And then we also most commonly put a polymer on the back of the kneecap right there. And a lot of the implants are made out of cobalt chrome. I have that question a lot. Occasionally titanium. And then the polymer is a high molecular weight polyethylene. So a long one to say, but a very good material to allow long-term use of the knee for many, many decades. So there are partial knee replacements, and you can see this, that it's only one part of the knee, usually the inside of the knee, but they can be performed on the outside. And these are very good alternatives because they don't change any of the ligaments. Normally with a total knee, you have to take out the ACL, and this allows a little different stability of the knee. And with the partial knee, the recovery is a little bit quicker. It feels more like your normal knee, removes the arthritis off the femur and the tibia bone on just one side of the knee. And I see many patients getting back to normal in 6-8 weeks. So I'd say about half the time of a knee replacement. Now the problem with this is it's not good for anybody who has arthritis anywhere else in the knee, under the kneecap, or in the other part of the knee, like the outside. Not a good candidate for a partial knee replacement in those scenarios. Certainly not good if anybody has rheumatoid arthritis or some of those inflammatory arthritis where there's crystals like gout in the knee. And then talking about total knee replacement, we kind of touched on it, but I'll show a few more details. We maintain the outside ligament, the MCL and the LCL, which is on the other side of the knee, and usually metal implants that go on the tibia and the femur, cemented on most commonly with the polymer in between, just for repetition. And the longevity of these implants can be up to 20-30 years is what we're seeing nowadays. It's mostly because of this polyethylene is lasting a lot longer. And so talking about what we have to do before surgery, really important to encourage weight loss. Any time you can get any weight off the knee, it helps a lot. Clear that. Weight loss is very, very important. Managing blood sugars in folks with a little bit of extra blood sugar in their system, diabetics or hyperglycemics. And then getting basic labs is important. We always have our patients before a total knee replacement visit their primary doctor, just check their heart and lungs, make sure they're safe for anesthesia and surgery. The nice thing is we're doing surgery today under spinal anesthesia mostly, with a little bit of sleeping medicine. And so the anesthesia is a lot lighter, although totally unable to feel any of the surgery, it's a very good option, but it allows patients to wake up and be much more clear-headed and able to participate in physical therapy on the same day, because I do allow my patients to walk on the same day after surgery. And total joint class is also good. It goes over some of the things we're talking about today, but also kind of the nuts and bolts of what to do before and after surgery, including dressings and showering and managing weight and that sort of thing. And let me clear these. And then the surgery itself, you usually have to arrive 2 hours or so before surgery. They always give you a call, let you know what to do, nothing to eat or drink. And I kind of go through this just to give everybody just a basic idea of what it's like to be a patient who undergoes one of these operations. And we talked about the spinal anesthesia, usually lasts about 5 hours. That's variable. The surgery is usually only the surgeon's part, and the surgical team really only needs about 2 hours plus or minus, depending on the surgery and the difficulty. And then a little bit of light sedation for sleep. That way you don't have to be awake for a lot of the clanging and noise of the surgery, which is nice. The surgery itself is a front of the knee incision. It runs right over the kneecap, and then we move the kneecap aside and are able to place those implants. The ACL is removed along with both of the meniscus pads. The PCL ligament can be removed, and that depends on the situation and surgeon preference. That's that back ligament. But a lot of people are maintaining it these days. And that gives a little bit, in my opinion, more normal feeling to the knee instability. And we touched on a bit of this. I'll move ahead. And then I just want to show a quick video. I'll kind of talk through it. And so this is a system that we do use here in Central Oregon, and goes through kind of just what we talked about the anatomy, and it shows here what the implants look like, which is really nice. So you have the patellar components on the front, the metal femur, and then the polymer in between. And this shows what the cuts do look like to remove a little bit of the bone. It's not a large amount to place both the implants, and then that polymer goes in between. And then we would put a polymer on the back of the kneecap, and this is what a total knee replacement looks like, and gives a good idea of what it is, kind of a before and after, allow us to walk more pain-free. So there are many different types of knee replacements, and we do robotic surgery, or the Mako knee, here in Central Oregon, and it's not a minimally invasive procedure. It is similar incision, and it's not really a robot. There's always a surgeon in control and actually using the machine. It's more related to a CAD design that actually uses a CT scan, a CAT scan that we get of a patient's knee before, and it allows us to very accurately and precisely place specific implants to the patient. So it's more of a navigation system, like kind of a GPS system for placing the knee replacement. Is it necessary? No. We've been performing standard instrumentation knee replacements for many years, and the outcomes have not really shown a difference. It can be surgeon preference, but this is a relatively newer option, and I do like it. I think it does work well for certain patients. And then there are also patient-specific guides, also based on a CT scan that uses 3D printed guides. Also not necessary. We use this in complex cases, but the standard instrumentation does work quite well. So this is what standard instrumentation looks like, and we have kind of alignment guides, is how I describe them, that help align placement and cuts to allow placement of the implants, and place them specifically for each knee size. It gives similar outcomes to navigated surgery and similar surgical times. So both are very good, and they're some of the most famous surgeons in the country do both types. Talking about the recovery, always a major question for me And it's extremely variable, depends on a lot on activity and conditioning of the patient beforehand. Folks that are all also very active before surgery tend to be more active after surgery. Maintaining muscle strength and mass is very important. But in general, kind of general guidelines that I give is that a knee replacement should regain full motion in about 6 to 8 weeks. And there can be a little bit of increase over the next several months thereafter. It's usually about 3 to 4 months before I want folks heading out and traveling, walking. I know we're all in our house. That's why we're doing a webinar tonight. And it's by the time we can get to travel again, it's usually about 3 to 4 months after a knee replacement. And then 6 to 12 months making small gains. There can still be some twinges and pain, especially as we increase strength. A lot of folks have been having a lot of knee arthritis symptoms for many years, and it's actually decreased the condition of the knee. So as we do more and more, there can still be some residual pain, just as if you're working out and starting a push-up program for the first time. It does cause pain. So as we get that strength back, it's really a 6 to 12 month recovery. I've definitely seen people who even after a year, they're still getting better and better. But really that first 3 months is the majority of the healing time, and good to know. So common questions that I get, and then I'll look at some of the ones from this evening. Will my leg be longer after surgery? That's not the case in knee replacements. No, we balance the knee based on ligaments, which only are a certain length, and a knee replacement can only go that far out. So no, it doesn't usually lengthen the knee. It can change the alignment of the knee a little bit. You can take a bent knee, a knock-kneed, or a bow-legged and make it a little bit straighter, and that can give a little feeling of length, but nothing more than that. So it can make you a little bit straighter. Will my knee beep at the airport? They're using X-ray scanners these days, but sometimes patients have reported it, and it's pretty easy to see when they wave the wand over it that there's a knee replacement. So TSA doesn't really listen to my notes anyway. So how long until I feel better? That's also very variable. I've had people who notice almost immediately the pain relief, and some people take a little bit longer. Sometimes it's about 6 weeks to 2 months. There's a lot of swelling related to a knee replacement just because it's a totally new implant. You've changed the nature of the knee in all in one day. So your body hasn't had a lot of time to adjust for it immediately. And it can take a few weeks, even a couple months to get more accommodated to that. And then how long does that knee last? It's very variable, but it's in the order of decades for sure. We're seeing those polymers last for many, many years. So the original idea that it's a 10 to 15 year option is not seeming to be the case, and that they're lasting much longer and are much more durable than that, which is great. So let's take a look at some of the questions, and I am happy to answer. So one question I have here is, do I see patients with a knee that worsens fairly rapidly after arthroscopy? And I have seen that. And sometimes that can be just the actual arthroscopy can increase the inflammation in the knee. If there's already underlying wear and tear, it's just the kind of the spark that lights the fire in the knee. And anytime we do surgery, there's always a little bleeding in the area, in the joints, and that can be quite inflammatory. And it can also just the pressure of the fluid we put in, or sometimes just the increased inflammation can cause the joint to be very unhappy afterwards. So I do see that. And then let's see. I see that there's one person's asking how long before we can get back to mild sports or activities. That's usually I've seen 3 to 4 month range. Depends what the sports are. If it's doubles tennis, it's maybe a little bit longer than if it's golf. Golf tends to be a little bit faster for folks, especially when they're using a cart and don't have to walk all the distances. And I have a question here of, can a person with a knee replacement get down on hands and knees? And that is difficult for a lot of patients, certainly in the first year. I've had patients who do a lot of finish work in houses and are plumbers and painters, and they definitely have to wear very large special knee pads to help decrease the pressure on the knees right afterwards, just because it's quite sensitive over the incision. But I do have patients after a knee replacement who can, and it's usually about a year before that sensitivity goes away. Let's see here. And then what about running? After a knee replacement, I don't recommend it. I do still believe that it's increased impact on the knee and it can wear it out over time faster. And the knee isn't quite as stable and in balancing that level of forces, and it can be awkward. Walk and jogging can be an option, but I don't recommend it. I think walking is the best exercise for it. And that's what I recommend my patients do. And then I have a patient that says they're signed up for surgery coming up, and they want to know what kind of strengthening exercises they can do. I think the number one exercise, and obviously this is pain driven, depending on how much you can do, is walking or using an elliptical, getting on an exercise bike, anything to keep the knee moving. And what I always say, it's kind of cheesy, is that motion is lotion for the knee. It just keeps the fluid moving, it keeps the capsule loose, and it definitely improves the outcome when a patient has been exercising their knee beforehand. Low impact exercise is important. Hiking up and down hills isn't the best, in my opinion. Running certainly isn't the best. High impact sports, basketball, soccer, those kind of things are a little bit too much. But anything that keeps the knee moving and keeps the muscles strong really does help. So those are definitely my recommendations. All right. Well, I think we are going to wrap it up there. I want to thank you for joining us for this first webinar. I hope this is helpful to everybody out there in the internet and in Central Oregon and beyond. I thank you for joining me for this, and I just want to point out that the center has a great website with a lot of resources that our staff has worked really hard on. You can visit the web pages of myself and the other doctors and get answers to questions about any of the surgeries and the options that we provide here for addressing knee pain and more. And we have links to YouTube videos and blogs that can answer a lot of questions as well. So I really appreciate you joining me, and hope to see you on the next webinar. Thanks a lot.